Hi, I'm Tom Myers, and I'm pleased to welcome you to part one of the two programs that we've developed for techniques for the deep front line. The deep front line is the last in the series of technique programs that we've developed based on the Anatomy Train's myofascial meridians. In this first part of the program, we would like to introduce you to the anatomy of this very complex area and to some of the considerations in working on these core structures. Then we'll go on to do some techniques for the lower part of the line. You'll find techniques for the upper body in part two of the Deep Front Line program. Although the various other programs in this series, the front, the back, the lateral, the spiral, the arms, and the functional lines, can be taken separately in any order and are pretty much co-equal, there is a real sense in which the Deep Front Line program is the last. What we mean by that is that we highly recommend that you undertake the work on the other programs, the more superficial work, with any given client before you undertake the deeper work you're about to see on this program. The deep front line is also called the core line, and it contains muscles and fascial structures usually referred to as core by the Pilates folks, PTs, and the followers of Ida Rolf. The recommendation here is that superficial structures need to be loosened and differentiated before you dive into the deeper structures of the core. In fact, too much core work before you loosen up those superficial structures can be damaging and leave the client worse off than before. So please, enjoy this program and these highly effective techniques, but please use them wisely, putting them to work after you've done several sessions opening up the superficial tissues and after you've established a good rapport with the client. We call this line the deep front line because it runs right up the front of the spine. It's way deeper than the superficial front line, which runs up the surface of the belly and chest. But since the deep front line runs up the front of the spine, it's still clearly an anterior or front line. In the leg, the deep front line runs a complex route from the arch up to the groin, but it essentially runs up the inner seam of the leg, and it counterbalances the lateral line that runs up the outer seam. In the spine, the deep front line runs right up the anterior longitudinal ligament from the pelvis to the head. This is also the attachment point for many of the organs of the chest and abdomen. Without making this into a long lecture, although I hope you'll come to a class sometime so I can explain it more fully, this front of the spine area, where the deep front line runs and the anterior longitudinal ligament is really the junction between the organs that hang off that ligament and hang off the spine and our neuromuscular self that surrounds it. So in a very real sense, when we're working in the deep front line, we're working on the boundary between our organic being and our neuromuscular doing. In practical terms, this means two related things. One is that when you're working on these tissues of the deep front line, you're working on the boundary between the autonomic system, the sympathetic part of it, the fight or flight system, and the parasympathetic, the repose and repair system. So what this means is that we're at the somato-emotional core of the client, and sometimes working with these techniques gives the client access to emotions that maybe you or maybe they didn't even know they had. This in turn means that we must work sensitively and with close attention when we're working with these tissues, and allow the client room to express themselves. Ida Rolf urged us to evoke the core. That means to call it out or call it forward, as she said. When you're working with core tissues, you're working with the human being, or you're working with the inner self. It's not just a question of pushing tissues around to correct things. Without getting too new agey about it, working with these core tissues really does require that we be present and that we call the client to be present as well. Which leads to my final caveat before we start working. A lot of pain can be stored in these tissues. The design of this work is to take pain out of the body, not to put it in. Be very careful of the level of sensation that you induce when you're doing these techniques. If your client's trying to get away, you're doing something wrong. There are many other techniques for the deep front line, including techniques around the throat and the pelvic floor, which we simply don't feel comfortable teaching on video. If you come to a kinesis class, we'd be happy to teach you those techniques in person, hand to hand. In summary, these techniques work best when applied slowly, with attention and presence, and with the client's cooperation in movement and in opening an area to new feeling. The rewards of these techniques are great in changed posture, in stress reduction, and in pain reduction, but those rewards will come only with sensitive application. The deep front line starts deep in the plantar surface of the foot, runs up behind the calf in the deep posterior compartment, swirls around to the front on the intermuscular septum, picks up the psoas, goes to the front of the spine, and follows the anterior longitudinal ligament all the way up to the skull. In that interface between the organic body and the musculoskeletal body, this is the deep front line. We're going to present these deep front line techniques from the bottom up, even though in practice you might apply them in a different order. And with each section, I want to give you a little bit of a review of the anatomy in case it's unfamiliar to you. In the lower leg, each of the anatomy train's lines takes up one fascial compartment. The superficial front line takes up the anterior compartment. The lateral line occupies the lateral compartment. The superficial back line fills the large superficial posterior compartment. What's left? The deep posterior compartment, hiding behind the tibia and the fibula and attaching to them and the interosseous membrane that runs between them. That compartment and the three muscles in it are the deep front line in the lower leg. Notice that all these deep muscles are covered over by that big old soleus, and indeed, if we look at the leg from the inside, we see these tendons coming around the inside of the ankle bone, but disappearing within a few inches up under that soleus. That makes these muscles difficult to access for manual therapy, but let's feel what parts of them we can before we work them. So sit with one leg crossed over the other and put your finger just under the medial malleolus. Now invert and plantar flex your foot as if you wanted to see a splinter on the bottom. The tibialis posterior tendon pops right into your finger right here, and you can feel how strong and substantial it is. A bit posterior to this is the flexor digitorum longus, which is coming from the little toes. This one's smaller and a little bit harder to feel. The flexor hallucis longus is a big tendon, though. If you put your thumbs into the space and go in front of your Achilles tendon behind the heel, and now wiggle your big toe, you'll be able to feel that tendon very clearly going up the back of the ankle. You can also feel that tendon running along the inside edge of the plantar fascia. If you take your big toe and hold it back, you'll feel that tendon coming right along the inside here. But if you try to follow these three muscles up the inside of the leg, going behind the tibia, they're very quickly obscured by the soleus, and you can't feel them anymore. So our hand placement is going to be crucial here to really get right in to find these three muscles. Good, so now as we go into the techniques for the lower part of the deep front line here, we have Leah to help us, being a model, and also Sean. We'll introduce Sean in a moment. But first let's get these techniques here. This first one, for getting into this deep posterior compartment. Now we saw how hard it was to reach this when we were looking at the anatomy, so the hand position is very important. To get to the deep posterior compartment, as close as you can, you have to take a really sharp turn around the tibia. Having positioned your client so that that inner part of the leg is open to you, if you can see how Leah is, she's lying on her side with one knee up, so I've got that inseam of the leg right down the table here. And I just, it's like take that skin on the edge of the tibia and go right around the corner and go in behind it. Leah, perhaps you can feel the difference between if I come back here, even 1/4 of an inch, and press in there, versus if I really go right behind the tibia. You feel that difference?
Definitely, that's much deeper, Tom.
Okay, so that's what we're looking for, and that's what you'll find. Leah's experience will be repeated by your clients. If you get right around the tibia, you'll find it. Now, which direction are you going to go depends on the situation that you're looking at when you did your body reading, when you did your visual assessment. If you have somebody who is supinated, who tends to wear out the outside edges of their shoes and the inner arch seems high, then you'll want to carry this tissue down while you're working. If you've got somebody with a low arch, with pronated feet or everted feet, you're going to want to lift this tissue up. So let's imagine that we're dealing with a low arch situation. Leah's arches are actually pretty good, but we'll pretend that. So the idea here is get right in behind that tibia and then begin to lift the tissue as she dorsiflexes and plantar flexes up and down with the foot. Or indeed, you can take that foot in a circle if you want to, Leah. That also is helpful. That movement just helps open up the tissue for me, makes it easier for me and easier for her. Once again, as we said in the introduction, be careful about your level. So I didn't ask her, so let's ask her now. When I am in here like that, is that a tolerable place for me to be?
Yes, right on the edge.
Right on the edge, okay. So, how about if you start into movement? Does that make it easier?
Yes.
Yeah, so you do the movement, and just for a lark here, I'll show what we would do if we were taking this tissue down. I'm right behind the tibia. It's almost as if I'm trying to scrape, except we don't use words like scrape, not in front of our clients anyway, the tissue off the back of the tibia, at least to open it and melt it and let it down towards the arch. All right, let's bring Sean on and teach him this technique. Okay, so I'd like to introduce Sean, a local massage therapist interested in learning some structural techniques, and let's give it a try. So, Sean, see if you can position your fingers the same way that mine were. If you find that edge of the tibia there, and actually pull the skin with you and then dive in behind, and Leah will tell you when you get to the same kind of place that I was.
That's about it.
Okay. Now, the question, the two people have to move, you and she. So first we're going to get her to move. Dorsiflexion, plantar flexion, bring your foot up and down. And now you could go either up or down, or you could spread your hand apart if you just wanted to open that tissue up. So see which one the tissue says it wants. Moving up or moving apart from each other? Yeah, it's spreading, that works well. Okay, now is he staying in?
Yes.
Good. So the only thing I want to play with here is, if you let your shoulders down and let it be, no, go ahead, stay right there. Let it be your pelvis that carries you into. Instead of getting the shoulders up, just get your whole weight on top of your hands and sink down in there. You might be happier with your hands straighter. Good. Okay, now she feels it. That opened her eyes. Okay, so you have to move now. Okay, that's good.
Can I take it up this time?
Yep. All right, now your idea here is to allow this tissue to open. You're just her assistant in getting this to open, yeah?
Yep.
So you should not feel done to. You should feel assisted.
He's starting to come out.
Okay, so stay in.
What's that?
That's better.
Good. Okay, I think we got it. You could carry that up. Let me just show you the limits of this motion. This could go up all the way to the knee, but what I didn't show before and I want to show now is that as you get to the knee, you get to that edge of the tibia where it goes out to the condyle, and you can go right out again. And as you can, I don't know if you can hear her breathing, but this is often a touchy place. So you can really go anywhere from just above the ankle all the way up to the inside of the knee. So lying there, client on the side and going to the inside of the leg, as we just did, is a very good way of getting to this deep posterior compartment. But if you lie your client on their belly, there's another way of getting to kind of both sides at once. Now with my left hand, I'm going right into the inside of the tibia, same as I did last time. But now with my right hand, what you can see on the camera here is that I'm going into just behind the peroneal, so I'm right up against the backside of the fibula. And if I get my elbows wide, I kind of pinch that deep posterior compartment. We don't use words like pinch. And now if Leah starts to move her foot, that's great, into dorsiflexion and plantar flexion. I have this feeling of being up against the backside of the fibula and up against the backside of the tibia, and I'm just working both of those with my elbows out wide. How's that feel?
Feels great.
Feels great? Mm-hmm. So I'm not in too far then, I take it.
That's right.
All right. Well, let's just check this out. How far could I go before I would really,
That's about there.
Yeah, that's about there. I'm now putting a lot of pressure on the bones, but if you keep moving, you'll find that that actually releases and it's not so painful anymore, is it?
No, it starts to slide.
It starts to slide. If you're really feeling, if you want to, and you don't have other things that get in the way, you can use your chest to create this passive motion if the client is having a hard time with an active motion. Anyway, let's get Sean on and have him try this technique. Okay, so give this a try now. You'll want to step right in. You may even want to put one leg on the table, I don't know. And get your hands right around the back of the bone and right around the back of the bone. And straighten your fingers and get your elbows out there so everything comes from your chest. It's like, I am Hans and you are Franz and we are here to pump you up. If you can just get in like that, that's good. Does that have the same feeling to it? Not quite.
When we start to move, I'll know better.
All right, so now you have to get your chest out of the way so that she can move dorsiflexion and plantar flexion.
I feel that the one near the tibia is not on.
All right, so hang on just a second. And the idea here is you're going to hook right around that bone. Does that feel more like it?
Better.
And you're going to hook right around this bone and then somehow get your fingers so they're opposite each other. Great. Okay, so now you move. Leah?
Yep.
Okay. And generally speaking, although you could carry this up or down, the easiest way for the practitioner here is to open this tissue by having the fingers go from the ankle to the knee. And the client just keeps the foot going in a circle or up and down. If you're a woman and you are well endowed on the chest, you have to be careful of that movement because it may catch you. So you have to stay a little bit farther away. Got that one, Sean? Feels okay?
Am I still in there, Leah?
You're starting to slip off, Sean.
Okay. So let me show you here. As you get down lower, if I get in here, as you get down lower, your elbows need to go higher. And I am even using my thumbs on the front to steady. Is that different? Am I staying in?
That's that.
Okay, listen, try that. Just put your thumbs on the front. Your fingers in behind the bones. Yep. Okay. The only thing I want you to do here is to try is straightening out your wrist. I'm worried about what will happen to your wrist in 5 years. That's great. Okay. Good. Okay. So before we let this go, I just want to show one more variation of this. I can't overemphasize the importance of this deep posterior compartment in the lower leg, and there are several ways to get at it. We'll try one more after this. But this is another variation. I would like to hold the bottom of the foot while I'm doing this, but I need my two hands up here. So I'm going to employ my third hand by sitting on her toes. So, yeah. And then I'm going to place my hands, as I had them before, behind the tibia on the inside, behind the fibula on the outside, and now I'm going to invite her to lift her heel up and down again. And lift the heel up and down again. So I'm doing very similarly to what Sean was doing before, except he was going up the leg because she was on her belly. I'm coming down the leg because she's on her back. What's that, too much? Getting close?
Getting close.
Okay. Getting overexcited here, so I need to cut back a little bit. Anyway, that's another variation that you can use to get in and open up these deep muscles back here. Let's see one more. So this deep posterior compartment, that is the deep front line in the lower leg, as we've said before, lies under the gastrocnemius and the soleus. Most of the time, you don't want to work the way we're about to work, which is straight through the soleus to this deep posterior compartment. It's too bad because it is, in a way, the most direct access. All of these other pinches and coming in from the sides here are kind of second best. But this is not really good either because you can make Swiss cheese out of the soleus, in other words, poke holes in it, on your way to the deep compartment. But if somebody, like Leah, has really soft muscles in the gastrocnemius and the soleus, then you can get through to this deep posterior compartment this way. Notice that I have positioned Leah so that she can dorsiflex and plantar flex. Her foot is off the end of the table to where she can do this without touching the end of the table. And then I'm going to take nice big surfaces of both hands and place it on the soleus. And now, Leah, you tell me when this... No, don't move yet. You tell me when that's enough. Please notice that I've got a big surface here. I'm not taking and... Yeah, I could lift her off the table if I get too specific. So I'm going to take a nice big flat of the hand, come back here to the soleus, and now you begin to move, and we sink down through. That's great, meaning that's enough, yeah?
Yeah.
If I were to go deeper than that, it would be very hard. Okay, so you can measure the amount that you do this. I do not want her trying to get away from my work, but I do want to get as deep as I can and still get the work done. And you can carry this right down, but notice when you get to the end, you're going to carry off a bit to the inside. And the design here is not to get to the soleus. You put your intent right down through the leg into that deep posterior compartment. Okay, Sean, let's give this a try and see if you can create the same feeling on the other leg here. So go ahead and lean in and, yep, get your body right up on top. And Leah, you tell him when he's getting down in there in the same way. And you send your intent right through that soleus down to the deeper part of the leg, and then begin to move down, and you begin to...
That's perfect. I wouldn't go any further.
Okay, and just begin to dorsiflex and plantar flex. And you're just thinking your way. There's the muscle, and then there's another layer of muscle, and then there's two bones. Can you think your way down to those two bones, the tibia and the fibula? And then just cut back a little bit to that deep posterior compartment. It has a different feel from the soleus. The soleus is muscly and pillowy and fluffy. The deep posterior compartment is very fascial. Even though those are muscles in there, they are much more fascial, much more dense, more slow twitch fibers in them, redder muscle, and they melt slowly into that. You doing all right?
Yeah.
Yep. You doing all right?
Yeah.
Good. Well, notice how slowly he's going. We can't continue this on for hours and hours on the video, but I really like that speed. The tissue melts slowly, and he's going along at the speed that the tissue melts. It's really good. It's great connection with the client, and that's what we want. Okay, so down below the muscles in the deep posterior compartment is the end of the tibialis posterior tendon. Now this is the deepest thing in the whole foot except the ligaments. It's a very complicated tendon that comes down into this whole metatarsal arch here. So if I put my finger, I'm going to use my middle knuckle, but I don't care which knuckle you use, into the foot right in the middle of the medial arch. Now I'm bending back the toes so you could see, but then you let the toes relax. In fact, put your hand on the top of the foot and bring the upper foot down over your knuckle in the lower foot. And now I'm going to go in as far as Leah can bear it. This is very good for people who have really had long-term no arches. And I'm going to ask you to extend your leg into my hand. It's like she's pushing out. You can't see this motion on the video, but she's sending her leg out through the bones into my finger. And in this way, she controls how much pressure it is. So if it's too much, you allow yourself to pull back a little bit. And if you can, you come in onto my knuckle more. I know that's a little bit weird, but for you to create your own pain. So how's that feel? Is that okay?
That feels great.
Okay.
I mean, perfect pressure.
Yeah. So don't allow your foot to invert like that. Make sure you're coming right down through that medial arch. That's it. Right out through the hip. So this is the exact position where we want the knuckle right into the first cuneiform. A little bit farther back than you might think in the arch of the foot. And now Leah, push. And all I have to do is keep it here, and she does the work by pushing down into my hand. That way she can engage just how much sensation she would like to create in this move, and I get the sense of connecting this inner arch up through the inner line to her hip and back. It's something where the client is required to create their own strong sensation by coming out at you, but it is a very good thing for helping to re-establish the deep connection to the arch via the tibialis posterior muscle. Two more techniques here before we leave the lower leg behind, two more on the foot actually. If you have a high arch pattern, such as we see in this photo here, it's not really a high arch. What you can see from the insert is that the foot is bent down. And what we're going to do is unbend the metatarsals with this technique. If you place your thumbs at the ends of the metatarsals, at the proximal ends of the metatarsals, and you place 6 fingers under at the ends of the metatarsals. So here you can see exactly where my 6 fingers are across the bottom of the foot at the base of the metatarsals. So then when I bring my hands over the top and get the thumbs on, those 6 fingers are right at the metatarsal bases. Bend the toes down a little bit so you can really get your fingers in the plantar surface underneath. You're not trying to get to the plantar fascia, you're trying to get through to the very roots of the metatarsals. Now, this takes a lot of hand strength, but it's a very good technique. Your thumbs go up towards the ankle, and your fingertips come down towards the toes. How are you doing?
Good.
You doing all right? Mm-hmm. So, which hurts, the thumbs on the top or the fingers on the bottom?
Fingers on the bottom.
Yeah, well, I'm afraid that's what should be causing sensation because we're going all the way through the tissues of your foot to get that. As you can see, I'm doing this several times, and I'm trying to work the tissue right on the bottom of the metatarsal. Did you see that? She was trying to get away from what I'm doing, so I'm working too hard. Even though I'd love to get this done, I have to do it within the parameters. So you breathe, and you tell me if I'm overgoing it. Actually, she can tell me, but I can see if she's trying to get away. So I need to gauge the amount of pressure that I create. But in any case, what we're doing is up the top of the foot, down the bottom of the foot in a very deep and pointed kind of way. All right, if Leah can bear this again, let's see about getting Sean on this. Okay, so let's have Sean give this a try. So you want to position your fingers so that your 6 fingers are right in a line. Your 6 fingertips are right in a line under the foot. There ought to be dents. Oops, no, this is the other foot, so there won't be dents in there where I was already. But right at about the base of the metatarsal, so here and on that outside little bump. Great. And the feeling is you bring those fingertips right into her foot. Is that more or less the same kind of depth?
More or less the same.
Okay. And your thumbs on the top are going to push toward her ankle while your fingers really grip. A lot of the time we like to use our body weight and come from the pelvis, come from the feet, but there's no question that this requires finger strength to get deeply into the sole of the foot, and it's almost as if you're working on the ligaments at the base of the metatarsals to open this up. So give him some sense of where he should be.
Deeper.
Deeper. Yeah.
Deeper.
Deeper. Deeper still.
It's.
Okay. So see if you can get your finger. It's almost dropping your wrist to get your fingers in. Mm-hmm. Okay. Now, by coming up with your thumbs and bringing your fingers out like that, you bend the foot. Are we getting it?
Yeah, it's like a fulcrum.
It's a fulcrum.
Yeah, I'm getting that now.
Yep. All right, so try it one more time. Just get the fingers on the top, the fingers on the bottom, and use the fulcrum to bend that bone off the rest of the foot.
Much better.
Yeah, I think he's got it now.
Yeah.
Good. All right then. So one last technique before we leave the lower leg behind for the flexor hallucis longus and especially related to bunions. Now, the flexor hallucis longus crosses in the lower leg, so if you want to get a hold of it, you need to go right around behind the fibula, right in here, and with your other hand, grab the big toe. You see how all my fingers are around the ball of the big toe? It's not grabbing the big toe so much as that first metatarsal. So my hand is not on the side where the peroneals are. I'm right around back. Have I got your attention, Leah?
Oh, yes.
Okay. And I bring my hands down in the lower leg and work the big toe back to the center. See how my fingers are underneath that big toe? Just bring it back towards the center that way. At the same time that I'm gripping down along the back of the fibula where this muscle is. Not the side of the fibula, that's where the peroneals are. I'm all the way around back of this bone, and I'm down here at the ball of the foot. pulling that out and forward. You're never going to really solve a bunion like this, but you sure can scare it some. You can straighten out a toe this way. The trouble is, as soon as somebody stands up, they're going to jump right back to where they were before. So you'll need something to hold their toes apart. Bunions are too long a discussion to have right here on this video. Come to a class and we'll show you how that works. This, however, is a great maneuver for somebody who's having big toe problems. From the lower leg, the deep front line passes along the back of the knee, including the popliteus muscle and the knee capsule, and then into the thigh. In the thigh, you can find the medial femoral epicondyle, which is a bony attachment important to our work. If you just slide your thumb down the thigh until you hit it about an inch or two above the knee. This is the lowest point of the linea aspera and where the two planes of fascia come together that enclose the dreaded adductor group. I say dreaded because this area is not touched very much. When are you touched on the inside of the legs? By a lover, a doctor, or long ago by your mother? But it's very important that we work this area because these muscles often don't feel like the books look as everything gets tangled up together and they need a lot of combing out. But proceed sensitively when you're working here. We usually use this position where we have Leah on her side with one knee up so that the inside of the thigh is exposed for working. These muscles can be divided into the posterior group, including the adductor minimus and magnus, which assist extension, versus the anterior group, longus, brevis, and pectineus, which assist flexion. The gracilis, the only two-joint muscle of the adductors, roughly divides the two groups. Without going into a lot of detail here, remember that all the adductors attach to the linea aspera, to this point on the back side, not the inside of the femur. Okay, so that's the theory, and that's the pictures in the anatomy books. But back here in the real world, on the real body, you can help find your way around the adductors by putting the same hand on the same thigh in this position. In this position, your thumb falls on the sartorius, your index finger falls on the big round muscle of adductor longus. Your middle finger, if you strum here, you'll often feel corduroy, and that's the gracilis muscle. Behind the gracilis is the adductor magnus, and where your little finger falls is the hamstrings. It's amazing how often this works. Of course, thighs are different size and hands are different size, but if you just open your hand, put your middle finger right straight up and down on the thigh, you'll really be able to find the muscles quite easily. To get a little more in detail here, the adductor longus is that big round tendon that you can feel on the close to the crease of the leg on the front. The gracilis feels like a bit of corduroy behind that. The adductor magnus is the big, heavy tendon behind that one, and way back are the hamstrings. So if I put my fingers somewhere between the adductor magnus and the hamstrings, if I have Leah pick her leg up in the air towards the ceiling, boom, the adductor magnus comes into my fingers. If I have her leave the knee on the table and come around here, now press your heel against my hand, boom, I feel the hamstring. In this way, you can orient yourself on the leg. Between the sartorius and the hamstrings are the triangle of the adductors. So really, once you understand the anatomy of this area, technique simply becomes a matter of finding the specific patterns that pertain to this person and helping them to let them go. This is complicated by the fact that these muscles are so close to the seat of sexuality and don't get touched except in a sexual context. For many clients, this won't be a problem, but for the ones for whom it is, circumspection and prior consent and sensitive working are very much required. Okay, so moving up now to the thigh, the first technique that we're going to do is actually not structures that are part of the deep front line, but while we're here, I think we ought to pick it up. And that's the pes anserinus itself, these three tendons that come right down in under the knee, like that. We're just going to take our fingers, put them under here, and spread up and out. Now, Sean, if you could take your knee back on the table and forward on the table. And back on the table and forward on the table. I'm just using my finger pads, my fingertips, and I'm spreading up. I'm not driving in his knee into the table. I'm going just into his knee to get this very superficial structure, this pes anserinus, and then by dropping my wrists, I'm going on up towards his thigh and spreading out. This is a nice way to ease up on connections on the inside of the knee and lift the pes anserinus. The technique for the adductors themselves, you remember we had this medial femoral epicondyle right here that we found earlier, and then just above that is the hiatus where the blood vessels come through. So no fair pressing really hard on that, yes? That's not something you'd want me to do, Sean, yes? So if you give an inch or two above that little bone, you'll be safe as we come to here, and our next technique is a very easy and universal one for the whole adductor group, which is to spread it away from the midline. Now I am putting my two fists on here. I don't care whether you do it like this or like this, but what you're looking for is to find the midline, sink into the tissue, and begin to spread the tissue left and right. Could you do that with your fingers this way? Yeah, you can, but you're likely to be held out on the surface, and Sean's got strong muscles here, so I actually want to sink in to his leg. Now, the other thing that we constantly call for here is movement. So, Sean, could you take your knee forward and back? Now, you can hardly see his movement on the video, but he is moving forward and back. Doesn't matter if they move any more than a half an inch. It's the idea that they're moving as you spread. And look at how wide my hands are going. You can take this right around to the front and the back of the body, then go up 3 or 4 inches, next fist's worth, so to speak, and open this up. And you can keep this going right up the body from the inside of the knee, up the inside of the thigh, towards the ischial ramus, and each time you just fall into the tissue, get set, and then spread that tissue wide as they take the knee forward and back, just as if they were walking a little bit like that. All right, let's have Leah practice this. All right, so Leah, give this a try. Start with your fingers just below the knee. You'll feel where there's a kind of little fat pad where those tendons end. And your idea is to get in there and almost lift those tendons off the inside of the knee, spreading as you go. Is that somewhat the same feeling, Sean?
Somewhat should be just a little deeper, perhaps.
She could be just a little deeper, perhaps. Okay. Coming up and spreading that. Yep. That's good. You will notice how Leah's leaning into it. That makes it a lot easier to do this work because she's doing it from her pelvis, not all from her hands. Okay, and underneath your index finger there, you'll feel that little bone, yeah? Mm-hmm. So you don't want to press very hard north of that bone because that's where the adductor hiatus is, where we have the
Blood vessels.
The blood vessels coming through, yep. Okay, so now change to this. You can come around here. Put one hand in front of the other. Yep, but you want to be right on the midline and you don't want to be on that hiatus. Okay, great. So now, before you do anything, you settle in. Yeah? She got good contact? Okay, and now you begin to spread, and he begins to take his knee forward and back. How's that pressure?
That's good.
Yeah? And how's that for you?
It's good.
Yeah?
That's like, as long as my body's over what I'm doing.
Yeah. So when you're doing this, go ahead and do another iteration of that. Don't forget to tell him to move.
And you move forward and back your knee.
Yeah. And with that, you can do this technique whether or not you know where you are or not, because all you have to do is find the midline and spread in both directions from the midline as they're moving. However, it's better if you know the specifics of where you are. So if you take your hand and just place your hand on his thigh, kind of, it's got to be the same hand on the
Yep.
same thigh. Your thumb falls in. You feel that valley where your thumb is?
Mm-hmm.
Yeah. That valley is where the sartorius is, and that's the front of the adductors. And we've already said that the front of the adductors is where the adductors are that help flexion. So with somebody with an anterior tilt pelvis, where the pelvis is tilted anteriorly, we want to lift this septum up. So take up from your thumb, put your right hand in here so it follows that septum. Inside your finger pads are the adductor longus, the adductor brevis, and the pectineus, and you are going to travel up towards his hip joint along that septum. We're used to thinking about muscles, but we're not used to thinking about working the fascial structures like this intermuscular septum in between. So what Leah's doing now is coming up the inside of the thigh on that septum, and in the process she's opening up and lengthening all the adductors that attach to that septum. Adductor longus, adductor magnus, and adductor longus, adductor brevis, and eventually pectineus. Now you can only follow that so far before it gets potentially dangerous, so that's the anterior septum that can be reached from this position. The posterior septum is between the adductors and the hamstrings. So if you have him bring his leg around so that the heel touches your thigh, then you press your heel against her leg, and now you can feel the hamstrings, so go right along the hamstrings. Now we're going to presume that he has an anterior pelvis, in which case we wanted to go up the front septum, but now you want to go down the back septum. So you come back here, and then lean in, and you can move your leg. Is that too much?
Yeah, a little bit.
Okay. Lighten up, you big bully. Good. Now, flex and extend your knee. It'll actually make it possible for her to come in farther without hurting.
Let your knee lead the way instead of your lower leg.
Okay, so in doing this, you'll find two things about this. One is, if they're moving, you can put more pressure in without causing the sensation of pain. And the second thing is, if you've got rapport and you swim your way in, you float in, you sink in, any word that works for you, if you let yourself into the body, the place where they stop having sensation and start having pain is going to change. So you're looking for that place, especially in these very delicate, not so touched areas of the inner thigh. Got that? Great. Okay. So we've seen several techniques for the adductors here as we move up the leg, and this next one is not for the faint of heart. We saw Leah going up the flexor adductors and down the extensor adductors, the adductor magnus and minimus here in the back, by going along this posterior septum. I just do want to emphasize before we go on that this is for an anterior tilt. We're feeding the front of the pelvis, dropping the back of the pelvis, and if somebody were in a posterior tilt, we might be tempted to go the opposite way. And this same thing extends up to where all these muscles attach on the ramus. I usually make sure that I'm taking underwear with me, and the idea here is that you're going to drop your fingers down into the leg and come up under that ischial ramus. Now the ramus is wider in women than in men in general, but I want to make sure that I'm on or under it. What I do not want to do is go inside of it. No fair going that way. But if I can get to the bottom of the ramus, oops, I'm getting close to lifting Sean right off the table. Is that okay? I'm there. This is definitely a touchy area. It, as I say, is not for the faint of heart, but it will give you a lot of reward in terms of this being the inside of the leg. Now, a lot of people may not think about it as the inside of their leg, but it is. And there are a couple things that you can do here. One is just to go back and forth. If you can see my fingertips going back and forth on the ramus to open up this tissue. So your hand is going to be going down into the leg and then up against this bone, and then you use your fingertips to clean either backward or forward. If the pelvis is in a posterior tilt, I'm mostly cleaning this tissue, taking it backwards. If the pelvis is in an anterior tilt, I'll be taking this tissue forwards, grabbing the tissue on the bone and moving forwards. Now, I'm using words like grabbing. We're in a very sensitive area, so you proceed slowly but definitely in freeing the tight attachments of these muscles as they come up. You'll feel very clearly the round tendon of the adductor longus in the front, and behind that is gracilis, and behind that is the tendon of the adductor magnus. Now, with the tendon of the adductor magnus, you have a very powerful place for lengthening the leg. Now, you get in on the leg and really drop down. I'm going to use Sean's face to tell me whether I am, yep, I'm lifting his eyebrows now. Are we getting down to about where I can be?
Yeah, that's probably.
All right, so I have pressed down, I'm pressing down onto his femur. I'm pressing down into the table, and I'm going to lengthen his leg by bringing my elbow towards his head and my fingertips towards his ankle. Okay? Now, the one thing that's missing in this is his movement. So elongate your leg out over the end of the table. Feel that? And one more time. I'm going to come up here, pin this tissue, and my fingertips are going down as my elbow goes up, and you elongate over the end of the table. You all right?
Yep.
You want to feel funny?
Yeah.
Stand up right here and just feel the difference between your two legs. Yep, stand up behind the table. Now, you probably can't see anything, but I bet you he can feel the difference between the two legs here. What's it feel like?
Ka-chunk.
Okay. It's very, very clear when you have this. Okay, so we've turned Sean over on his other side so that when Leah does these same techniques, we don't end up with Sean walking in circles because one leg's so much longer than the other. So Leah, what I'd like you to do is use the whole hand on the leg. When the whole hand arrives on the leg like that, it's a lot safer than if you're poking around with your fingertips. That's kind of upsetting for the client, if you see what I mean. And take the cloth with you, the cloth of his underwear, and go down into his leg and go up and tell me when you found his ischial tuberosity or ramus. Actually, it looks as though his jaw is tightening, so what's happening there?
I think she found it.
You think she found it? Okay. So, what's the difference between the way she was doing it and the way I was doing it?
Nothing. I may just be more sensitive on this side.
Okay, so he's a little more sensitive on this side. It's not uncommon at all to be more sensitive on one side than the other. So now, that's good. You're in there. You can begin to explore that bone, yeah? And you're wanting to be outside as much as possible on the bottom or the outside of that bone. You got it? Mm-hmm. Yep. Okay. And if he were anterior tilt, you would be taking it forward. If he were posterior tilt, you'd be taking it back. Yeah? So this is one of these areas where you can explore if your client is open to your being here. You can explore here for a while. It should be right in that place between pleasure and pain, and you're opening up these muscles that nobody has ever touched with this intent before. Now, that's not true of everybody, but it's true of most folks. Okay? So we'll leave you to explore that off camera. I want to try this other one. So stay right there, but turn your attention and your intention to going down through his leg to the table. Don't go all that way. If you get splinters in your fingers, you've gone too far. No, we're just trying to get down towards the inside of the femur, up under that ramus, down towards the femur. Yeah? You all right?
Yeah.
Okay. And now, to open up his leg, you're going to send your leg out over the table, and you're going to bring your shoulder towards me and your fingertips towards his heel. It's a crowbar. We don't use words like crowbar either, but it's a crowbar kind of wedge that you're using here to lengthen out, and you're helping her by sending that leg out over the end of the table. You know? Doesn't feel like you're quite in the corner. The femur is like a figure 7 in there, and you're trying to get into the corner of the femur. You can't because the tissue is too dense, but I know what it is. Your shoulder's going behind yourself. Get up on top of your shoulder. That's it. And then wedge that thing down. That's better, isn't it?
Yeah.
Yeah, that feels more like it. I don't know if you can see this on the video, but I can feel it right here. That was catching his leg and sending it out. Okay, so we just tried to lengthen Sean's legs, give him model-like legs on a side lying position. You can also do this supine. It again is going right into the groin. We'll be doing several techniques in the groin here following. So to get there, I lift the skin up, put my whole hand on the inside of the leg, and drop down into the inner aspect of his leg. I put my other hand on the greater trochanter on the outside of his leg. I'll show you this on the skeleton in a minute. And then grab between my two hands, making sure that I'm not pressing against an artery in the process, and pull both hands towards me. Bring both hands out towards me. And Sean, you can help by just extending your leg right out straight, sliding your heel out the table until it gets to be straight. That's good. And come back up again. Bring your knee back up as I bring this out. Now, again, this is not for the faint of heart, and you do want to make sure that you don't have anything untoward between your fingers and the legs, because that hurts more than is necessary. So, I know this is a little weird. This isn't Sean. We didn't make him anorexic. This is my skeleton, but I just wanted to show you where we are. So, when I'm coming in here, I'm lifting the skin, I'm dropping down into the groin. The artery comes right across here, so I'm being careful to avoid that. And I'm going in the direction of the lesser trochanter. I know I can't reach it in most people, but the idea is we're getting at the bottom of the neck of the femur here, and by getting on the greater trochanter on the outside of the thigh, we're getting both of these, and the idea is to bring traction that femur right out of the socket by coming up on both sides of the leg. So when we had him lying on his side, we were coming in and doing it like this. When I had him lying on his back, we're bringing the leg out, both from the greater and the lesser trochanter. I hope that makes it a little clearer. So, from the touchy inner thigh, we're going to go to the equally touchy groin. Doing manual therapy here is really a measure of your skill. How do you get deep enough to cause tissue change and postural change, and yet still stay sensitive in this very personal part of the body? And how do you stay away from creating danger in what is essentially an endangerment site? We're going to show you the basics of the program here and leave the rest for when we see you in a class. The groin, right in the front of the hip, is where the superficial front line crosses over with the deep front line, as that deep front line turns from the inside of the thigh with the adductors we've been looking at over the front of the hip before diving deep again to get to the front of the spine with the psoas. Thus, right in the front of the hip joint is where the psoas, iliacus, and deep front line in general are closest to the surface. That's because the human hip hangs out. Its postural normal is what would be fully extended for any animal. We flex easily, but even for us, to bring the hip any further into extension requires that the lumbars go into hyperextension. You don't get much more extension out of the hip because the ligaments tighten up. But take any one of your local four-footed animal friends and attempt to bring the femur around so that it's in line with the spine. Angie likes it all right, but any more than that and you'll see that she gives you a nonverbal message that animals don't like having their femur in the fully extended position. Our own hip tends to get short in the front, either because developmentally it never opened in the process of our standing up, or it shortens up later due to trauma or habit. When this happens, that tends to produce an anterior pelvis. The anterior pelvis tends to pull on the spine tends to pull on the diaphragm tends to pull on the neck, and you end up with a host of problems that are really coming from here. So therefore, even though this is a difficult place to work, gird up your loins, take a deep breath, and give it a try. You'll be gratified with the deep and lasting results that you can get here, and if you get over your squeamishness, you'll find that your clients get over theirs. Okay, so although we're going to go deeply into the groin here a little bit later, let's start with something a bit superficial, and I must say almost everybody, no matter what their pattern, can use some opening in the fold in the hip joint for the reasons we just discussed. So we're here with Sean and Leah. I'm going to show this to Sean and have him do it, and I want you to tell us whether we're getting about the same on both sides. So lay your arm, is it lay or lie? Lay your arm anyway across the length of her body this way, and I'm going to go up inside, just inside the ASIS and just outside the pubic bone, and I'm going to invite you to just lift your knee and now push out with your heel. The pushing out with the heel is important. That's where she gets the length through the back of the leg and the front of the groin. So you lift your knee a little bit. I have your attention now, yes? Yep. And you just go right over the underwear with this and right into the belly. Although I am not pressing into the belly like that. I am just going superficially. I'm aiming in the direction of my fingers. If you see where my fingers are, I'm just going right across like that. Okay, Sean, why don't you give that a try? So first sink into something like what I was doing. You can tell him when he gets there. And then just move up. You know what? I have a superstition. My superstition is 2 hands on the body. Yep. So figure out a way to get your other hand on her. And first your knee comes up, and then your heel goes out. So is he getting the same kind of thing as I was? And once again, it's coming from his back. His elbows being moved by his back up Leah's body. And Leah's movement is really allowing us to open. It's a simple move, but you will really get some initial opening of the groin. And you want to do something like this before you start diving in the way we're going to be on the next move up. So the first place that we're going is, after this initial groin opening, is to the iliacus muscle. If you find the ASIS and just go over the edge of the ASIS and curl your fingers back towards the inside of the iliac bone. The iliacus muscle covers that whole thing, so you could be right up close to the ASIS, or if the client allows, you could go further back and get a hold of that muscle. Once you have a hold of that muscle, which is really covered over by a tough iliac fascia, so it's not just the muscle, it's the muscle and the fascia together, then I'm going to invite Leah to just slide her leg out straight, and in that process, she's going to stretch the muscle and the fascia together. And now draw your knee back up. There's only one essential thing here that you need to make sure of. When she takes her leg out, as she gets to the straight leg, if when she gets to the straight leg, the lower back comes up off the table, she goes into an anterior tilt, then you're not doing much with this. So I would just add, for those people with a sway back or a strong lumbar curve, okay, so now I've got this muscle, I'm pinning this muscle, and you keep your lower back against the table as you take your leg out. Ooh, that was fast. Can you be just, especially this last bit here, can you be a little slower? It'll be easier on you as you stretch out through that muscle. You feel that right in there? Okay, and then bring it back up. All right, let's see if Sean can find the same place. Okay, so you're hooking back into the inside of the hip bone. Yeah, so that got about the same feel to it? Yeah? All right, so now slide your leg out straight. That's you. And push the heel, same as we did before. Can you feel that stretching underneath you? Okay, great. And then draw it back up again.
It was hard to move at first.
Yeah? Because he was different, or because this side's different from the other side? Yeah.
Different from the other side.
So that's really common, that one side's going to be different from the other side. So one of the things we're trying to do is balance the hips by getting these to be similar toned. But the fact that it's different from one side to the other doesn't mean necessarily that you're doing it differently. It probably means that their two hips are different. Everybody has a dominant hip, and you could call it differently. You could call it a gestural hip and a postural hip. And the postural hip, the one they lean into, is likely to be tighter for the iliopsoas. Now, there's a lot of controversy around contacting the psoas muscle, but for my money, it's a good place to be because I want full awareness for the whole body. So, in contacting that, though, I do it a little bit differently from how you may have been taught it, if you have been taught it before. Go right over the ASIS, same as we did for the iliacus, and here I go, sliding down the slope of the iliacus. I must, sooner or later, run in with my fingertips into the psoas. Of course, I could also run into an intestine here. How do you know the difference? The difference is when she lifts her foot off the table, the psoas gets tighter and intestines don't. So I'm pretty sure I'm on the muscle there because as soon as she lifts her knee, boom, there I am on the muscle. Now, in terms of opening this muscle, I want to be very careful and very slow and very deliberate here because I am working through 2 layers of peritoneum. You can't not be. You may not be pressing on an intestine or stretching anything, but you cannot avoid going through 2 layers of peritoneum. So I swim, I'm sensitive, I let her do most of the work. I come up against that outside of the psoas or perhaps against the top of the psoas. But now, what I'm going to ask you to do, Leah, is take your knee out over your second toe. Now, I'm being very precise here saying the second toe, but that's where we really would like it to go. And at least over the toes, not with the knee going to the side, either the outside or the inside. And then I just use my fingers as guides here to help open tight places. And you may notice that where I'm looking is not where I'm working, but in her eyes. The psoas is such a deep muscle, so close to the core, such a toxic waste dump sometimes, and so important that I want to know where Leah is at. And the eyes are the window to the soul, and the psoas may be the most important structural muscle, but yeah, right there. Yeah, now I found a place where I really would like to open that. And that's probably enough. That was a fairly long move. And if this was the first time that anybody had been in Leah's psoas, I probably wouldn't have been there so long. You really will excite stuff out here. This is a muscle that carries a lot of garbage in it, and if nobody's ever been touched there before, probably a smaller amount of work is going to be sufficient. If somebody has more experience, you can stay there longer and work with this motion. Okay, Sean, why don't you give this a try on the other side so she doesn't get too unbalanced?
Tom, can I see where you placed your hands there?
Sure. If you find her, you can just cover one hand with the other hand here. Now, don't get your shoulders up. It's going to be real easy, real gentle. You find the ASIS, you feel that? Mm-hmm. And you just get a little north of it, a little on the top of it, and then slide down. So before, we hooked the fingers into the iliacus, didn't we? But now we're just going to go right down beside it.
Well, it's very sensationful.
Okay. All right, so back off a little bit.
Just that.
All right. Now, lift your foot off the table. Do you feel the muscle ahead of you? That is the psoas muscle. Now, if you're feeling kind of burny, gassy type of feelings, he might be on a visceral connection.
Definitely a psoas connection.
This is a psoas muscle connection. Yes. All right. So now you just go into it a little bit, and you can gauge the reaction of her eyes, except she's closed them. So now take your both knees out over your toes. It's not just one. Take both knees. And you feel that muscle? You can explore it by tipping your fingers a little bit that way. You can find different parts of the muscle to explore. And you're just melting. You're just melting into that muscle. How's he doing?
I feel like he lost the connection.
All right. So
Sync.
you keep your hands still for a second. Lift your foot off the ground. Got it again? Mm-hmm. Yep. Okay. Excuse me for this, but just relax your own neck. So you elongate, and then you just fall through your hands. There, that feels better. Because you're not talking to her muscle qua muscle. You're talking to the psoas as a major guy wire between the leg and the spine here. So allow that to open. That feels much better. Good. All right. Good, I think you got it now. We'll leave you to explore that off camera, and we'll go on to the next technique. Now, whatever you do in the iliacus and the psoas, make sure that you finish up with a balancing move that includes both sides. This is not hard. It's not difficult, should not be painful, but it is important. So I put my ring finger on the two ASISs, right up against those bones, and I have 3 fingers located across the body here, and I'm going to drop back into the same area that I've been working. So the iliacus is against my ring finger, the psoas is against my index finger, and I'm dropping into this corner of just above the hip joint, essentially. Yeah, that's okay? And now I'm going to have you take both knees out over both toes and tuck your tail under. And then I can just fall back. Sean, if you'll notice, I'm just falling back in. And now lower it 1 vertebra, that vertebra, then the next one, then the next one, then the next one. Like it's a whole chain of dominoes coming down. And I just keep my hands in here. It is not a big, heavy move. I'm just guiding her psoas and checking the tonus of the two. So, ring fingers against the ASIS, drop in, dropping back, not to where it's painful, but to where I'm in contact. Now, tuck your tail under and send your knees out over your toes. Ooh, slower. Okay? So, tuck under slowly, send your knees out over your toes, and there's where your vertebrae are. There's where your psoas is. Now, just drop the topmost vertebra back on the table, and then the next one down towards your sacrum, and then roll into your sacrum. This opens up those vertebrae between L4, L5, and S1 so that you can really get your back long and flat. Okay, Sean, give it a try. You okay for him to come in
Yes.
now? Yeah, it should be gentle, not stressful. Okay, so make sure your ring finger is right on there, your fingers are horizontal, and you just drop back there. And you're reaching across with one hand, so use the pressure in your fingers to make sure that you're quite even on that. Does that feel similar? Okay, so now drop your pelvis back and take this up. All right, so don't turn your fingers in too much. You're still going down towards the table. Yep, that's it. Are you getting a similar feeling with him that you were getting with me? Yeah, good. So you use the cue. What do you want her to do?
You want to just drop your top of your lumbars and what did you do again?
Yeah, the cueing is really important. How you talk to the client. Okay, no, you keep your hands there. That's all right. We'll do it. It really helps if you get the proper cueing for this. So come on up with your tuck your pelvis under, send your knees out over your feet. Yeah. And now drop whichever lumbar is off the table, and then the next, and then the next. And you just follow it, kind of exploring in, keeping those two psoases balanced as she comes down all the way to where you're resting on the table.
Great.
Yeah, got it? Okay. I do want to show one other way of reaching the psoas. It's a one-sided way. When you can't do this thing on the back, you can adopt this alternative way. Okay, so let's see one alternate way here of working with the psoas in side lying. It has one disadvantage and 2 advantages. The disadvantage is that side lying, working with the psoas side lying, is not as good as way of working as lying on the back in terms of the position of the psoas and the balancing between the two. The 2 advantages are, one, that the organs fall away from you, so you're less likely to get involved with any intestinal attachments as you come back here. Now, the way to get back here is to slide your hand back along the iliacus the same way that we did until you contact the psoas. Are you unsure as to where the psoas is? Just put your hand on the model's knee and she presses against my hand. In other words, she flexes the hip against resistance and I can boom, boom, feel the psoas right in there. And now we get to the second advantage here, because now that I've got the psoas and I can explore it and I can hold the back of her hip with my hands. So you see how my hands are opposed. And now, Leah, just bring your knee back and keep bringing your knee back. And that's the other advantage of this side lying position. She can go way past just being straight to actually hyperextending the hip. Okay, come back around again. So watch. She starts from flexed, I'm holding on to the psoas, I'm stabilizing the hip, and she goes past that as if she were running, as if she were leaping off her leg. Okay, bring it on back. So there is an advantage there, but you obviously can only work one side at a time, so be sure that you finish up with that lying on the back, two-sided move to keep things balanced. Now the last part of the psoas complex here, besides the psoas and the iliacus, is the quadratus lumborum, or as my French student calls it, le carré des lombes. I like that better than quadratus lumborum. But QL for short. It runs right down through here, and many people say, okay, I'm going to work on the quadratus lumborum, working here in the lower back. Well, as an anatomist, I'm here to tell you, you can't reach the quadratus lumborum from the back like that. You may be doing great work in the thoracolumbar fascia, you may be doing great work with the iliocostalis, but you're not going to get the opening or the balancing between the rib cage and the pelvis that you're going to get if you really get the QL. So there's technique on the QL, but first there's finding it. If you reach over the edge of the iliac crest so that you're on the inside of the iliac crest, somewhere forward of the midline. If you see, I'm anterior to the midline here. Now I walk my fingers back along that midline and I find this piece. So Leah, you feel the difference between doing this and doing this? What's the difference? How do you...
It's so much deeper where you are right now.
Mm-hmm. Got you really by the quick if I'm here. Okay, so this, where I am right here, is the outer front edge of the quadratus lumborum. Outer front edge of the quadratus lumborum. So I'm going to reach around, hook my fingers over that, and bring it down and back. And perhaps you could hear Leah taking a breath or see her taking a breath. Her breathing is really helpful in opening this, and so is this idea of bringing the hip away from the shoulders. But just to demonstrate this is not how I work it, but I just want you to see it with the fingers. I'm coming down in on the midline and then hooking this muscle back towards the back. Now, I said muscle. I make that mistake sometimes. But the muscle and fascia together here, this is a very important part of this complex because the quadratus lumborum continues on into the iliacus. So when you free the iliacus, you've freed half of it, and when you free the quadratus lumborum, you've freed the other half. What I don't want her to do, I'm very happy for her to reach down this way with her hip. What I don't really want her to do is to reach up with her arm. Try reaching up with your arm. Now reach way up there. Wouldn't you think that, just stretch your hand way out. Now, wouldn't you think that that would stretch out this quadratus lumborum? But instead, it tightens up the latissimus that's running over here, and then you can't get into the QL. So bring that arm back down again. If you want to have her open this up, I'm sorry, this is a very touchy area. Just use breathing as you bring that edge down to the hip and back. You don't want to push up on the QL too much because you're going to encounter that 12th rib, and that's a slippery and delicate little devil, and you don't want to push too hard on it. Okay, so let's have Sean try this. Okay, Sean, we want to make sure that you really get in on this muscle and feel it for yourself, and once you've felt it, you'll never have to be in doubt again. So if you go over the edge of the iliac crest, nope, not with that hand because that's behind the midline. Now, walk your fingers back until you feel a kind of strip or a cord going up towards her ribs. Can you just keep walking back there? You won't miss it. Just right there. Feel that? All right. That's the outer edge of the QL. Now your idea here is to get your fingers in and actually catch it so that you could bring it back. That way that's going to help stretch it and also help bring it back in the body. Most of the time the QL is too far forward with folks who have an anterior lumbar curve. And it's usually too short and too held in those that have a posterior set of lumbar. So in both cases, you want to get this muscle to open. Okay, so Leah, is this about the same, what he's doing?
Something quite not the same.
Quite not the same. Oh, don't leave. All right. So we'll come in here, hook this,
There.
and bring it backwards. You feel that feeling? It's a very core feeling. It's one of these things. In the deep front line, where we're not working on the surface of the body, we're working very deep.
I can feel that onto the other side, actually.
Yep, okay, that's great. So do you feel that now?
Yeah.
Feel what happens when she takes a breath. Take a nice deep breath. You feel that stretch out from under your hands. So you catch it, and especially on the out breath, you bring it back, and then she breathes in. She does the stretching. She does the stretching when she's breathing in. You don't have to work at all. They pay you, and they do the work. It's great. Okay? So all you have to do is be in the right place. Good. Are your fingers collapsing on that?
A little bit, yeah.
A little bit. Okay, so go ahead and re-catch that. So here's the corner of the hip, and you're going right in that corner, hooking that baby and bringing it back and getting Leah's attention. Yep. Okay, I think you got the idea there. There's lots of work to be done, but really getting to the right place is the secret here. If you get in the right place, they'll open themselves up, and you don't really have to be that... Yeah, you do have to be that skilled. But once you get that place and get it to open up, you'll find your skill increasing each time you get there. It's just a question of starting from in front of the midline and getting in front of that muscle. Coming back to the posterior side of the adductors for a moment, we saw how the posterior septum can get tight in and of itself or stuck to the local hamstrings, and we worked that with Leah. That posterior septum also crosses up the inside of the ischial tuberosity over the obturator fascia and connects up with the muscle of the pelvic floor. There are a number of ways to reach the pelvic floor, but most of them are beyond the scope of what can be taught on video. But here's one approach that is really quite profound and fairly easy and not so invasive. So, Sean, I'm going to ask you to lean over on one cheek, and I'm going to carefully go in under the other and find his sits bone and have him sit down. Go ahead and come back and sit down. Oh, yeah, it was not quite far enough in. I want to be a little bit farther. So his sits bone is sitting right into the crook of my fingers, but my first fingers are on there. You see how I can move his spine from here? Okay? Now, my hand could go on his shoulder. In Sean's case, it's going to go on his hip. And I'm going to ask him, I'm going to put very slight pressure with this hand and very slight traction with my underhand. So I'm pushing with my upper hand, pulling with my lower hand. And then I'm going to ask you to go into an anterior tilt, go forward on your pelvis, and then tuck your tail under, go backward on your pelvis. And I'm going to ask him just to move around several times with this so that he gets a feeling. This is not so much of a fascial move as it is a reorienting or a neuroeducational move. And then go over onto that cheek and then settle your weight right down onto my hand. And kind of roll around on that sits bone. You can carry this on for longer than I'm carrying it on right now. And the idea is while he's doing this, you're just keeping a gentle traction. Now, you may be tempted to do this for too long, but I'll tell you, my fingers are beginning to lose blood, so you can't do it for too long. All right, but if you want to feel something funny, watch what happens when I take my fingers out. Just sit into both sides. You feel the difference?
Yeah.
What's the feeling?
This side feels somehow more to this side than this side does.
Yeah. About 3 inches lower on this side, if I may lead the witness. Yeah, have a stand up and see if you feel a difference standing up.
Oh, yeah.
This is really just the dropping of the pelvic floor. His sits bone, his ischial ramus is sitting right down on my hand like this, and I'm just hooking my fingers up. All right? So, Leah, see if you can make him feel a little more even. So, what are you going to tell him?
So, Sean, I'm going to have you lean over onto the other sits bone and then come down onto my hand slowly, wherever that is. There.
Yeah, it takes a little while to find this. Now, men usually have the sits bone a little more narrow than the women, but you don't want to go too far.
Go back the other.
Yeah, so sometimes you have to have them come up several times because you don't want to go too far, but you do want to have the bone sitting in your hand like that, so you could pull it towards you. Yeah, have you got it, or you want to? Yeah, that.
Moving his body.
Yeah, you're moving. That's right. You have his whole body in your hand. Okay, so now the other hand goes on the iliac crest, and you have a slight push with that hand and a slight pull with the hand underneath. And see if you can maintain that idea while, Sean, you go back and forth. Okay? So he's going to just rock and roll forward and back, a little bit left and right, and
And rock back onto the other sit bone for me again, and come back again.
you're repositioning yourself?
Repositioning.
Yeah, okay, so you get the, you'll know when you get the right one. It just sits right down into your hand, almost onto the
Men
ball.
are so much narrower than women.
I see, yeah.
Okay.
So, after you've done this and your fingers are beginning to lose their feeling because he's been sitting on them for a while, then you just push him over to the other side, take your fingers out, and you stand up and see if you don't feel a little more balanced this time.
Yes, very much so.
Now, that may not seem as though it's a technique for the pelvic floor because you're not directly on the pelvic floor, but by working on the sits bones that way, the feeling that he has of dropping into that leg, or the feeling that the sits bones drops into the floor, is a feeling of the pelvic floor relaxing onto the hand. This can create more awareness in the pelvic floor, so it's not a bad exercise for those who have low pelvic floor tone, although you're also going to need to do some exercises in which you increase that tone of their pelvic floor, if that's the problem. This brings us to the deep lateral rotators, a set of 6 muscles that don't fit easily into the anatomy train's scheme. To the extent that they do fit, they're really part of the deep front line, connected to this posterior septum that we just explored with the adductors. But I don't really think that they should be called deep lateral rotators. As far as I'm concerned, these muscles are the extensor coxae brevis, the short hip extensors, and really should be treated in that way. In a anterior pelvic tilt, these muscles need to be, well, the fascia around these muscles needs to be dropped. In a posterior pelvic tilt, they need to be widened. Okay, now the deep lateral rotators are a very complex area in terms of pelvic mechanics and their actions, and to go through all the details of treatment would be way beyond what we can do here. I do refer you to the Anatomy Train's book and some of the articles that I've written on this. However, what we're going to do here is make sure that we're accurately finding 4 separate myofascial structures here. The backside, the trailing edge, the posterior edge of the gluteus medius, the piriformis, the obturator internus, and the quadratus femoris. If we want to be really down and dirty in terms of treatment options here, with somebody with an anterior tilt pelvis and a strong lumbar curve, you're going to want to take this tissue, all of these muscles, all of this tissue down. With those who have a posterior pelvis where they're tucked under and they have no rear end and the back is flat, you're going to want to, thank you. Okay, we're going to want to loosen these muscles out to the side. There are a lot more details than that when we start talking about sacroiliac joint problems and various sciatic things going down the legs, so we're being very general here. But one thing that you can get out of this is being quite precise to find these things. So if you find the PSIS, which is this big knob of bone that is right where the dimple is, and you find the top of the trochanter over on the side, if you want to see that on this side, if you find the PSIS, which is that big knob of bone by the dimple, and the top of the trochanter over here, that is the path of the back edge of the gluteus medius. Especially in people with an anterior tilt, that will be a locked, long, eccentrically loaded, to talk in physiotherapy speak. But in any case, you can usually lift them off the table if that's very tight. Okay, so if we were going to work that, in Leah's case we would want to drop it down. I'm going to hook an elbow or fingers, but save your fingers. Use an elbow on this big structure, and I just hook it and bring it down and a little bit out. Strumming across it is maybe very stimulating for the person who's on the table, but it's not that much fun and it doesn't do that much good. You want to catch it and bring it down. This is from this dimple down to the top of the trochanter. Okay, Sean, you want to give that a try? Find your 2 spots, draw an imaginary line between them, and bring it down. Okay, so how's the feeling?
Not the same.
Not the same. What's the difference?
He's not as high up as you are.
Okay, so maybe you want to go a little, no, a little farther out and come at this from the outside. There you go. Now go ahead and strum across it a couple of times and you'll feel it. Do you feel it there?
I think so.
You think so? I think so too. That's actually not the piriformis. Many people go after this thinking that it's the piriformis muscle, but it's not. It is the back of the gluteus medius. That doesn't mean it's not worth working on. It definitely is, but it is not the piriformis. The piriformis has effects on the sacrum, and that's also a good one. So, if you found that, we'll leave you to treat it another time, and we'll find the piriformis. If you find the top of the sacrum, which I usually do by just sliding my hand down and seeing where it catches, which is often at the L5-S1 junction, and the bottom of the sacrum, so my thumb and forefinger on the top and the bottom of the sacrum, and again finding that top of the trochanter, the top and the bottom of the sacrum, and the top of the trochanter right there, because that's where the piriformis goes. See how I've made a triangle? The piriformis is right in the center of that triangle. The best place to reach the piriformis is right in the middle of that triangle. Now you're working through the gluteus, so sometimes you can't feel the piriformis directly. It's deeper than the gluteus medius, and it's for sure deeper than the gluteus maximus that you're working through. So your attempt is to hook onto that and bring, especially in Leah's case where we've got a bit of an anterior pelvis, to bring that down. But finding the piriformis and being very precise about where that is, yeah, that's another table lifter right there. So that's the piriformis face that you just saw on Leah there. So go ahead and use your markers to make sure that you're in the right place for that. Good. Now find the middle point. And again, we're going to, in her case, come down on it from above. And I know you don't like the feeling, but I would like you to help him get in there so that he feels it.
He's not deep enough.
Okay. Now, okay, and it's just leaning from here that will get you deep enough. That's it. Not pressing with your elbow harder, but just letting more weight into the body. Okay, that's good. You got it. So, we found the gluteus medius, the backside of the gluteus medius. We found the piriformis. The next one down is the obturator internus. This is a very important muscle for the pelvic floor. It reaches around into the pelvis and interacts with the pelvis floor. And it's a good one to find out here. So the way to find it is to find that ischial tuberosity. And to do that, don't poke around with your fingers looking for it. Just put your hand on the back of the thigh and then use your fingertips to find the bone here. And then walk up over the ischial tuberosity, straight up towards the head, literally letting your fingers do the walking. And I tell my students it's like walking up a mountain, and then you find a meadow near the top of the mountain. It gets soft. That softness is what I'm strumming over now, is where the obturator internus makes the turn and comes out to the outside part of the body. And I'll guarantee you that from this point it moves horizontally. So come ahead and find this and then begin to walk up over just with your fingers, staying in contact with the bone. That's it. And the next move there, you'll probably feel something soft. That is the obturator internus, and it goes straight out from here. And where it goes straight out from here, it picks up the two gemelli muscles, the gemellus superior and inferior, and all three of them come across here. So let's use our fingertips, and come across here and see if you can feel that. And that also can be a lifter off the table for those who are, we won't do both sides at once, that's unfair. Go ahead, you the work there. So again, with somebody like her, what you are looking for is to get above it and hook it down towards her feet with serious intent. These are deep muscles, they're tough muscles, they're fascially very thick, so you're going to need to get on top of them and kind of scoop them down towards the feet. Now, Leah, if you want to help here, you can do one of two things. You can turn your knee in to increase the stretch on that muscle, Or you can do the same thing that we did before, which is to reach out with your leg down over the end. You see how that's going to help you bring it down?
Yes.
So you get up on top of it, get in there, and then say, Leah, lengthen your leg, and you go down with her. Yep, that's going to really allow those muscles to release and let go.
Lengthen your leg, Leah.
Yeah, that's a good idea. Good. All right, the last one of this group of 4, the gang of 4 here, gluteus medius, piriformis, obturator internus. The last one is just above the gluteal fold here, and that is quadratus femoris, and that goes from the outside of the ischial tuberosity over to the back of the trochanter. So about where my fingers are here. Now this is not usually a big twangy muscle. You can twang on this, and twang on this, and usually lift the client right off the table. But this last one is a square quadrate muscle, as the name implies, and it feels kind of like a little mound, or a little, what do they call those things in the road, a little sleeping policeman on the back of the femur. So you're not probably going to feel a twang, you're just going to feel as if you go up and over a muscle like that. That, however, belies its importance. It's very important, and those with the anterior tilt, once again, you're going to want to take this tissue down, and it's a very fascial muscle, you're going to want to hook on it and bring it down. On those with the tail tucked under, where everything looks as though it's going into an uptight situation there, you're going to want to work out from the ischial tuberosity to the outside. Okay, see if you can find that same muscle on the other side. I will say that if you're below the gluteal fold, if you're down the shaft of the femur, you're probably working on the gluteus maximus attachment. That's fine if that's what you want to do, but the quadratus femoris is north of the gluteal fold. So I don't think you're out far enough. What I want to do is situate you on the back of the trochanter there. You feel the back of the bone? Feel the back of the bone down in there?
Yes.
Yep. Okay. Now if you go down over that way, is that about the right place?
Yep.
Okay.
Yeah, I do feel.
And do you feel a little kind of mound that you're going?
Yep, sure.
Yep, that's the one. All right. So in her case, you would want to hook that tissue and bring it down if you could. And you could actually even go up this way. Try it. You could come up here and push down instead of pulling down. Okay?
And with her assisting me as well.
Yeah, with her assisting you as well. Same thing as before. Okay, come on back to this side. And if she were posterior tilt pelvis, you'd want to be catching this stuff and working it out to the side. Okay, so there you have the gang of 4. I think I'll name them the gang of 4 now. The posterior edge of the gluteus medius, piriformis, obturator internus, and the quadratus femoris. Obturator internus takes in 2 others of the deep lateral rotators, gemellus superior and gemellus inferior, and in this way you're reaching down to these deep structures of the deep front line, the back part of the deep front line, but nevertheless part of that. And I know this has been very basic, but I hope the directions as to how to find things have been helpful. Okay, well that concludes this program, part 1 of the techniques for the deep front line. We hope you had some fun and got some new stuff out of this program. We recommend that you go on to the associated program here, part 2 of the deep front line, in which we'll explore techniques and approaches for the upper part of the deep front line.